This is our first of 5 sessions entitled Making AI Human webinar series. And so for this session, we are going to talk about how AI is rapidly reshaping healthcare. But for community health centers, the strategic opportunity is not automation for automation's sake. We're going to talk about how we use AI to protect our mission, improve patient-centric care, reduce burnout, increase access, and strengthen the financial engine that sustains care. For the executive level sessions, Thrive and RainTech will co-present a side-by-side dialogue that frames AI as a human capacity amplifier. Very important, not a staff replacement. We'll define the core elements of an AI strategic specific to safety net realities, aligning to mission, selecting technology, implementing security, reframing workflow roles, and establishing governance, and sequencing adoption to ensure sustainable return on investment. So with that, we're going to start off on what brings us here. Why are we doing this series, and what motivated you to team up? So I want to start with introducing ourselves so that you have an idea of who's presenting this series. So Andrew, why don't you start off?
Thank you very much, Dr. Powell. Yes, my name is Andrew Jahnke. I'm the founder, CEO, and people person here at RainTech. We are a fully and co-managed IT and cybersecurity service provider with a specific emphasis and focus in community and nonprofit healthcare. And so we work with FQHCs both here in our backyard and across the country to help keep them secure and safe. And we're now also an AI developer and partnering with our friends at Thrive to bring these kind of solutions to the FQHC space.
Thank you, Andrew. What about you, Bill?
I'm Bill Franz. I'm the president of Thrive. We're a team of individuals with health center experience. The majority of our team came from health center leadership. What we do is we work with health centers to build their capacity, whether it's from a clinical, operational, financial, or strategic optic. We have built lookalikes. We have worked with health centers to help them through financial stresses, and we've significantly improved operations at health centers across the country.
Thank you, Bill. And my name is Dr. Kerri Powell. I'm a pediatrician by training with more than 25 years in healthcare. I have been in population health and FQACs most of that time, and then currently started out as a primary care and now has worked as the CMO and a CEO of a fairly qualified health center. So not only am I here to moderate this, I'm you. I am here to learn and figure how this works with our FQACs. So I'm going to turn it back over to you to say what motivated you to come up with this series and to team up together particularly?
Well, although we have clinical expertise, operational expertise, financial expertise, all those things I previously mentioned, one of the gaps we had was really in the technology area. And with the onset of AI in healthcare and how rapidly that is being deployed and utilized and becoming a necessary tool, we had to find the right partner. Now, Andrew and his team here at RainTech, they were a natural fit because they have a human-centric approach to AI. Again, not using it as a replacement, but really amplifying it and bettering the functionality of staff, improving their workflows, making their jobs easier, as well as improving the patient experience and improving quality. So it was a natural fit.
That's right. And from our side, I would say the same thing. We've been working with AI since it came out. We've been deploying AI in production in our own company here for a number of months. And our skills there are only, getting sharper and sharper all the time as AI continues getting better and better. But we needed to partner with someone who also understood health center operations at a much deeper level. We've got a lot of healthcare IT experience, and we've been embracing HIPAA for many years, and we're a compliance vendor as well. However, that is not the same as understanding operations the same way as former executives from health centers at Thrive. So that's why it just made a lot of sense to work together.
And growing up in the nonprofit world and in health centers, the human element is so important. And do you mind calling up the hierarchy of needs slide? One thing, and I have to give Lisa Peterson credit for this. I've stolen this hierarchy of needs. She had adopted it to taking Maslow's hierarchy of needs and adopting it to employees. And in order to have satisfied functional employees, we need to bring them to the top of the pyramid. And part of this series is talking about how we can do that and how we can elevate your employees to perform better and be more satisfied in their work.
Yeah, I think doing both of those things is key. And that's certainly what we've done here at RainTech. When we started deploying AI in production, we used it to roll out a 32-hour work week that once for us was unthinkable. We wouldn't have thought that we would have had the capacity to serve our customers, and yet it's enabled us to do exactly that. And you can imagine how much more competitive that makes us as a technology provider. And so we're looking to bring that same leverage to the community health space.
Wonderful. So let's start moving right through this. Let's say what's real today and what's not. What does the future hold? So the first question I have is there's a lot of talk about AI in healthcare. So where does that technology stand? I know I'm curious.
Well, that's a great question, Dr. Powell. Initially, the most obvious one that most people are aware of is the AI that's been embedded within the EMR. So things like ambient listening, which is a very natural fit. That's exactly a perfect use case for AI to be listening to normal dialogue between doctors and patients, and then translating that into and transcribing that into a health record. And then ultimately, from there, it moves on into things like code scrubbing and optimizing for claim submissions and things like that. So the AI workflows really, began there probably, and then have been sort of spiraling out through the rest of the health center and operations to where now there are workflows that don't even touch EMRs. So now we just use them for just regular knowledge workers and people who are moving and processing information in a multitude of ways. And so there's almost an endless list of ways that we can now move these same capabilities into production.
Yeah, a perfect example outside of the EMR, and we know that all the EMR vendors are introducing AI into their systems, but something as simple as purchasing an AP, that can be a very burdensome process. But having AI automate those workflows under design parameters of who needs to approve what, et cetera, can significantly reduce the pushing of paper and the effort involved there. So, we talk about EMRs having AI embedded, but there's really three models for AI. And I think Andrew can explain those much better than I can.
Sure. No, thanks. So it's very important to understand anytime you're looking at an AI solution or an AI relationship, really, or vendor partnership is what you're also looking at. Because when you make a decision, just like when you choose an EMR, you've got long-term, implications associated with that. And so the first one is AI platforms, the thing that most of us are pretty aware of now, and that's where all of our chatbots like GPT or Claude and Gemini, they come from. And so these are powerful platforms that have the latest and greatest reasoning models, and it's where really all of this technology is pouring out from. However, there's nothing specialized within them. So the analogy that we like to use is that this is like having all the greatest ingredients available to you, and yet you have to have a chef that can come in and make the dish that you want, and then you can have an absolutely fantastic dish. But you sort of have to be the type of organization that is so forward-leaning, or that is a technology organization that has that level of expertise, because this is sort of what's software engineering is now evolving into. So that's the first one, is really just kind of AI platforms. And then you have vendor embedded AI, which we've touched on a little bit already. And so this is AI that gets built into things like EMRs. There's a very natural fit for something that's doing, ambient listening, and that's translating that and using a workflow to make sure that things like billing and RCM get optimized for that. And so there's some pros and cons there. This is like having somebody there that's giving you these pre-cooked dishes. And if that's a dish that you really want and it satisfies all of your nutritional needs, that's great. However, there are some that don't, and there are nuances around, say, state-level Medicaid, verification requirements and things like that, that not every EMR vendor is fully satisfying or has satisfied yet. And there will always be these edge nuanced cases, and even cases, to Bill's point, that are completely outside of the EMR. And so you won't be able to just lean on them to hand these solutions to you. But where they exist and where they're a good fit, and where you're able to make sure that they satisfy security and compliance requirements, that can be fantastic. And then lastly, you have an AI development partnership. And so this is where you work with organizations like RainTech and Thrive to say, what does AI really present to us? What sort of potential can we really take advantage of by leveraging this as a technology? And so that takes people with the understanding, both operations and finance and administration, governance, and all of that, along with security and technology, to marry that technology and say, hey, how do we fill this gap where maybe this other solution didn't? So this is more like having a personal chef that's going to come in and make exactly what dish you really want to be made. And the cost structures associated with these are different. It's important to note, though, that this is not the same as writing custom software was, a decade or two ago. This is not nearly as expensive nor as long a process to build a custom AI solution or what we call an agentic workflow. But that just means an agent is just a little piece of software that's running that leverages some AI to do its particular function. So when we refer to something as agentic, it just means it's software that's working together in tandem with AI, which in this case is what's called a large language model in most cases, but not all cases. And so this is where you have the utmost flexibility, and this is where you can fill the hole and have the AI function exactly the way that you need it to in your health center.
And I know I got a great slide that we can summarize all that you touched on as we move through further discussion with these three AI adoptions, or the three different versions. And so, Bill, I'm sorry, I interrupted you. I didn't mean to do that.
No, I was going to parlay on what Andrew said with the three models. Really developing the solution for your particular health center, your particular community, your particular patient base is critical. We know that there's a lot of burnout in the workforce now. There is financial instability or questions about future funding. So operating as efficiently as we can is critically important. But also, again, bringing it back to, we need to retain our workforce. We can't burn them out. And using AI to assist in that and assist in employee retention is critical. We can't just say, hey, we're going to be recruiting and we'll get who we need. We have to retain and elevate our existing employees.
Oh, and I think that they'll expect it as well, Bill. I think that workers in and outside of community health are quickly becoming completely ramped up, not just on the use of chatbots, but really the rest of the automation and capabilities that AI is bringing. So I think to remain not just viable, but really highly competitive as an employer, leveraging AI solutions is going to be key as we move forward.
Well, I'm glad you're touching all this, because as an FQHC executive, I find that all of this talk about AI, all of the different options that are available and all the things that it does, one, you can get concerned, and I know our staff gets concerned of, are they going to be replaced? Are we going to not have a personal touch to our patients? So can you just touch on what is why this matters for us as FQHCs specifically? Just tell us a little bit about that.
Well, I think we do want to focus on the patient, of course, which is, using AI to not only improve efficiency, but using those tools to leverage them to increase the quality of our care and monitor the quality of care. Again, through ambient documentation, note-taking, real-time conversation capture, these are some of the things that can assist your staff in operating more efficiently and providing better service. Again, we want to reduce the number of clicks, and we want to have that face time with the patient be the most important part of the interaction, not clicking in an EMR.
I think that's a really good point. The things that AI are best at, Bill, sort of assisting humans with are the highly repetitive tasks, the things that like this thing to go do this thing requires logging in or checking 2 or 3 or 5 different locations or websites or what have you to go do this thing. And that's keeping that person away from being able to provide more face time and higher quality interactions to the patients.
And with the financial pressures on health centers now and funding uncertainty, we are going to continue to move towards value-based reimbursement. And having AI in your quality process will significantly increase your opportunities for enhanced reimbursement from your payers. That's the take that we have on it.
Oh, yeah, to the same point where something is so time consuming to go collect and formulate and format all of the information, the data, the reports that you guys need to in order to optimize reimbursements and even just make sure that you're complying with federal regulations. There's tons of opportunities there too.
So glad you touched on that, because all we hear and see is all of the compliance, data-driven requirements that we have. So it's good to know how this would fit in our day-to-day and also help our bottom lines, because we know that we're at FQA and safety net organizations. We're struggling as time goes on. So let's just move on to the next topic, capacity and amplification. And this is where I know the scary part. These questions are: is automation narrative dangerous in FQ8C culture? You have these movie theater movies when you see the Terminator and the computers are taking over and they're red eyes and they're stealing our data and exposing everything. I'd like for you to just speak to our concerns and our fears.
Well, I think that you have to, first and foremost, we formulated this series to start to address these exact kind of questions so that we can move people into where they can start to leverage and get excited about the potential. But you can't do that without having addressed some of what are legitimate fears or understandings and somewhat might be misconceptions. So ironically, you bring up Terminator, like Skynet. That's one of the things that people ask me about when I'm like delivering these workshops to PCA conferences and things like that. And people ask, like, is this, kind of where this is going to go? And that's not entirely off base for kind of 2 reasons. Sometimes researchers will set up AI in a lab environment and outfit it in a very particular way with lots of access to do lots of things, and then tell this singular sort of agent to be responsible for a variety of things, and they'll create conditions that agent will then make choices or do things that are maybe averse or against what it is that the developers or the researchers who are running these experiments have told it to do. And so this spurs these kind of questions like, is this the beginning of sort of like Skynet? And it's important to realize that AI, what we call AI, is not intelligent. And so it's kind of a misnomer as it is to even have the word intelligence in there. It's a large language model. And so it's just like a word calculator is what a lot of people describe it as. But it was trained on the information produced by humanity for literally all the centuries that we've been recording it. So all the open source data that these companies like OpenAI and Anthropic could put into their models, and some not so open source, by the way, is what they were trained on, so that these models know how to calculate what the next word is on any particular thing that they are trying to analyze or reason on. And so, yes, the Terminator and the Matrix and all these other storylines in pop culture are a part of what they were trained on. And so we can't be terribly surprised that in a lab environment, when it's configured with just the perfect storm of opportunity and access and all of this, that it will do things like this, because that's how it was trained. And that's what it's come to sort of understand, if you want to say that word, itself to be. But that's really not what we're talking about here. What we're talking about here is much more like traditional programming. So it's a regular instruction, think of a thermostat in your house. If the temperature rises above 73, kick on the air conditioner. It's just if then. It's very deterministic. And so we're just introducing a little bit of interpretation into that. But that doesn't mean that we're giving this program any access to do anything other than interpret a particular input. So instead, it might say, if the user says it's too warm, turn on the air conditioning. And then if the user says it's hot, that AI knows that, oh, that means it's too warm. And so I'm going to turn the air conditioning on. And so it's giving it this ability to interpret what is not necessarily hard and fast input in order to create consistent output. And so when used, in a very specific fashion like this is where all of the potential of AI really unlocks for organizations that see how it really can work for them. But again, we're not doing things where we give just one, sort of big AI model blanket access to anything really. They just operate in very quick, successive executions of code.
Yeah. And I think it's important to mention that health centers are great at delivering their mission, and they're obviously mission-focused organizations. And you would deploy AI just like you would deploy a new program. You need to be mission-centric. You need to focus on your goals, focus on your patients, and focus on your employees. If you have that, so to speak, you control the plug. You can unplug it at any time. You're going to test your data with basically false or synthetic patient records, and you'll know it works before it's deployed. So I think focusing on mission, focusing on your patients and your employees during the deployment of AI will enhance your mission and enhance your capacity.
It also has a lot of transparency baked in, and this is important that as the regulatory environment catches up, and so there's proposed rule changes around HIPAA and other compliance frameworks, transparency is everything. And so again, this isn't like a black box where decisions are just sort of magically being made and we don't really know why. Because everything is happening programmatically, each one of those little analyses that's done on a particular piece of input and then decided what sort of an action or an output is going to look like is recorded, and it's recorded in immutable storage. And so you can always go back and you can actually look and see exactly what it did and why. And maybe even more importantly, and to your point, Bill, when you do move to start deploying these AI solutions, they start off in a very passive manner. It's basically just, your user might be seeing reports that it basically says, here's what I would have done on each of these things. And your user is basically the one that's saying, yeah, that's accurate. No, this one's not. And so that information gets back to the developers, and then they modify the logic a little bit, and then your user continues using it, and they keep watching those reports until that accuracy has met or even exceeded the threshold of accuracy for what a human is doing. And then we move it into a little bit more of an active role where it might be like a one-click commit. So now you have the AI comes up and it says, oh, here's your sort of work list. And still your human is there and looking at it and saying, oh yeah, this tracks, that's correct. And again, as the system performs and everyone sees and trusts that it's working really well, then you can turn that automation up a little bit more. And then it might be that the user is now looking at reports retroactively. So it might be that they're regularly reviewing what was done and saying, oh yeah, that's still accurate. This is still correct. This is still the right choice to be made in that case.
Thank you, Andrew. That's just you kind of frameworked our next session. You're telling me all about this technology, how great it can be to integrate into the health center. Talk to me about how do I develop a strategy? Now I'm interested in adopting this. How do I, as an executive, develop a strategy to onboard AI, make the decisions about what platform, what usage, and particularly for the community health centers and safety net organizations, and maintain what I do as this mission-based work?
I think that the answer has to be cultural to begin with. And I'm going to ask Bill to kind of dive into that because he and his team understand these mechanics at a cultural level for health centers far better than I do, for sure.
Yeah, so, mission focused and focus on your organizational culture is critical in developing the strategy, and knowing that roles are going to change within your organization. And so you need that pathway or roadmap for those changing roles. We're trying to increase some efficiencies to have more face time with the patient, for instance. Well, what does that MA role look like? Are there additional tasks they can take on? Those are the things that we have to plan for and get ready to implement along the way. So changing roles. And the second part of this too is your governing board. A lot of you probably don't have experts in AI on your board. And so education of your board is going to be critical so that they understand that this is not Skynet. And they understand that it's going to enhance the patient experience, enhance quality of care, and improve overall employee satisfaction.
Yeah, I think really leading with how employees win. Sorry, Dr. Powell. Leading with how employees and patients win, I think, is key to adoption. And just as we've been saying, the workflow requires your people who know these operations intimately, and this is their job, and that's why it will never replace them. They have to be the ones to oversee and to guide the efficacy and the performance of the solution itself.
I also think that it's important to start off slow. We need to not take the most difficult tasks and try to fix them. Let's start with some of the more simple tasks and address those. And get your staff, get your board, get your patients used to these small changes. And then as you progress, you can further develop your AI usage within your organization and continue that efficiency growth and that satisfaction growth.
If anybody's board is like mine, return on investment is going to be one of the things that come out of their mouth. So if you could just quickly just touch on that for us.
Sure. I think that the key is starting with what Bill and I have been calling these quick wins. So they're high value target workflows that don't have a lot of complexity. And that's not to say that AI can't handle a lot of complexity. Actually, computers and AI specifically are really good at handling a lot of complexity. But in order to get something in place that's going to be done relatively quickly, and it's very easy for everyone to see what a turnkey process that was, that it was planned for, that the metrics were collected ahead of time, like what does success look like here? So how much time or money is currently spent on this particular workflow? And then what does that look like afterwards? And how do we continuously improve that process? And so with a relatively straightforward workflow where you've only got, say, one or two data sources, it could be something going into or coming out of the EMR or the accounting system or ERP or any third-party system. Really, it's just a simple, we need to move something from here to here, and there's some level of analysis or something going on in the middle, then that's relatively straightforward, can be developed in a relatively short time frame. We're talking, in the matter of generally weeks, as opposed to months or over a year for very complex traditional software. But even more complex AI workflows can be developed in a matter of months, and again, not stretching out into something so much longer than that. So the key is choosing high value targets that have a relatively low cost to achieve, so that you can establish that as your foundation, and your staff and your stakeholders and board can all see that ROI much sooner.
And this leads right into the next topic that we want to talk about, because when we were all told to go to the EMR, and I'll speak for myself, maybe I'm the only one that made this mistake. When we were going to evaluate these systems, we spent sometimes tens and tens of thousands of dollars, a lot of manpower, only to find out that this system did not work well for us, that it did not address a lot of the compliance reports and things that we needed to do, and we ended up having to scrap it, start new, sometimes once or twice. So my next question would be, how do we avoid these vendor traps, these lock-ins, the compliance landmines?
That goes back to the three approaches, if we can bring that back up again, because again, this is a double-edged sword in a way. The vendor embedded AI solution might be among the least expensive because it's sort of developed once and deployed many times, but there's virtually no flexibility. And if it misses the mark by a little bit or by a lot, doesn't matter. The chances of that going to be a complete solution in any kind of a tangible time frame are very low, because they're moving on to the next thing on the product roadmap. Whereas if you have a development partnership, well, then you're the one that's actually deciding what everything is going to look like. And really, it's not done until you say, yeah, this is done. This is exactly the way that I want this particular audit-ready report to look, or this is the way I want this exact workflow to be functioning. And then that's when we say, okay, that's great. And so then from there, you're using it in production, and your development partner is monitoring it and optimizing it, allowing for newer advancements or new models to make it more accurate, adjusting logic. If you do replace a piece of software, large or small, it's a relatively trivial thing to go in and change this custom agent-based AI solution to now talk to this other piece of software. But this solution is now yours. It belongs to your health center, and you are the one who has described and dictated exactly what you want it to do. And so even if you do move out of some of these other vendor relationships, you're able to adapt this solution to work with whatever that new platform might be.
And in health centers, we see the quality program, taking data from the EMR, taking data from the financial systems, taking data from various sources, and we put it into our quality reports. With AI, you can take a more holistic look or optic at your organization, and you can look at the data across your organization in one place, essentially, is the way that I look at it. So you're not looking at siloed data, you're bringing it all together and reporting out on it. And so you can marry financial data with clinical data much more easily through the development partnership approach with AI.
That's a great point, Bill. In the vendor embedded AI, those vendors, whether they're EMR or ERP or accounting, they are vying for your mind share. I mean, and the feature sets, like they want to make sure that you are going to renew again next year. And so they do focus somewhat on interoperability, but those things that are truly valuable to you as a health center are not typically as valuable or even on their radar, because they aren't looking at a workflow where somebody is going to be comparing or aggregating both clinical and financial data, for example. Whereas something that has an AI-driven component can easily aggregate that data, surface it, put it into one place, and allow you to interact with it, visualize it, even query it and ask questions of it in just one place. And so it kind of empowers the executive and the decision makers to have more information, more available, more readily, than having to go dive into all of these siloed locations, where again, those vendors, those applications, they really want you living as much in their application as possible. But that doesn't mean that they're playing with the other applications that you use, and that they're working with those vendors to make sure that everything is fully integrated and interoperable. They just don't necessarily look at it through that lens. They say, how do we make sure that our users are getting everything that they can out of our software? And so, I mean, there's nothing necessarily wrong with that. It's just, it doesn't necessarily produce maybe what would be the best aggregated solution, to Bill's point.
Yeah, and you can control your data, you can control the security. And one of the important items to note is you need to know how AI is using your data, where the data is coming from, and in order to interpret it. There will be roadblocks or bumps along the way, but the more you understand the way that AI is working with your data, where that data is coming from, how it's being compiled and evaluated, I think you lessen the risk of mistakes happening.
Oh, for sure. And the new compliance proposed rules coming out around HIPAA and security are starting to mirror what we're seeing elsewhere in the federal government. And so the compliance boundary, if you will, is going to be pushed far outside of the health center itself. And so today we have this sort of self-attested process for risk assessment and analysis and controls that is now going to be evidence-based, more than likely moving forward, and it's going to extend to the vendors that do house that data for you, and potentially exponentially to the AI vendors, for example, that they might be leveraging after that. So you might have your EMR vendor that's hosting your data, and now you might be required to to get their annual risk assessment documentation and their digital pen testing information to make sure that you're satisfying your own compliance requirements. And then if they're leveraging any other third-party providers, for example, on the AI front, then you're going to have to extend to that as well. Now, this is not set in stone, so these are proposed rule changes, and we'll have to see how they shake out. But if they do start to adopt some of the things that other parts of the federal government are doing, like CMMC in the DoD space, if it starts to look like that, then the compliance requirements and burden on the health center are going to become nearly exponential based on those types of relationships versus, for example, the one that you work with a partner to develop internally, where all that information stays either in your infrastructure or, say, in infrastructure that partner hosts for you, like, say, in Microsoft Azure or something like that. But then it doesn't go beyond that.
So talk to me about, let's say I'm ready to go. I've heard everything you said. I've said this is what I want to do. As an executive or in leadership, what is the steps that I should take? What should I do to start to implement this process?
Well, I think first is starting with the human, right? You really need to define your statement, the human statement. What is this technology? How is it supposed to enhance the patient care? How is it supposed to enhance the workflow? And really define that and make sure that you're keeping the human focus there. Your CFO more than likely will come up with some ideas for projects that are those short-term wins, where we're going to see that near-term return on investment, where we're going to see the impact, and that will help with the buy-in. From a technology standpoint, I'm going to hand that over to Andrew.
Sure. I think that what's going to make sense, and we're going to dive into this, I think, in subsequent sessions in this series, is probably standing up internal working groups. And so this is going to be kind of cross sections across the health center. There'll be representatives from clinical and operational, administrative, governance, IT, and they're going to start to work through the process of attaching values to Bill's point with the CFO or to whoever has those numbers. And they're not always going to be dollar amounts, but it could be hours and it could go all the way down to outcomes. It really depends on the workflow, but you need to start to attach sort of value and what's the complexity here. And so is there a shorter win versus longer? And you might still decide to go on those longer ones. But you have to start to draw the landscape of what the opportunities are and start to involve those stakeholders in the organization that do understand where the pain points are. They understand where people are spending lots of time doing repetitive tasks. They understand where there's accuracy problems or where there's security problems, and having them start to surface what's the most important things in their health center. And then after that, choosing which of these different approaches is going to be the best fit to satisfy those. Are there vendors that already have an AI solution that fits really nicely and satisfies a particularly high value target for the health center? That might be a really great solution. If not, if it's something that's really complex, for example, or you have staff on IT that are super software engineers already and already leaning into this stuff, they might build you something from scratch using an AI platform. That might take longer, but can be pretty powerful. There's more compliance to be aware of there. Or you're going to choose a partner and you're going to work with organizations like RainTech and Thrive to say, okay, this is kind of what we're seeing is what might be high value targets. And then we're going to help map that to, this is actually something that, could be developed in a matter of a handful of weeks or maybe a couple of months before we've got something ready for production and ready for you to start working with and optimizing. And then that's it. You're kind of off to the races because you've made sure that your security and your guardrails and your compliance and everything are taken care of from day one, which is not always the case if people are using those AI platforms right now as chatbots. As I deliver these workshops again at some of these PCA conferences, I've learned that there's people out there that, of course, they're allowed to use GPT. They use their personal GPT, or they might even have a paid account through the organization. But there's no either policy or governance around that. There's no data loss prevention strategy that's preventing PHI from being submitted to a public LLM. And if you just go to ChatGPT and you upload a spreadsheet full of patient information and you say, hey, help me understand something within this, you've crossed a compliance boundary there. And a lot of users may not realize that because they're not necessarily thinking, well, I'm not sharing it with anyone or anything like that. But if they do share it, if they share that conversation in ChatGPT, which all of these chatbots have the ability to just go click share, if they share that link with someone else, that's now crawlable, which means that's searchable and indexable by Google, for example. So as soon as you create that URL, it can be crawled and searched and indexed by Google. And so a patient could go search their name at some point, theoretically, and find something about that conversation associated. And so we've got a real potential for data leaking out, which is not a lot different, by the way, than what we've had for many, many years. I mean, anyone that's got access to personal webmail at work, or anyone can exfiltrate data from a health center organization relatively easily if appropriate guardrails have not been put in place. So in that regard, this isn't that much different than what we've been doing for many years. We just have to make sure that we're addressing it specifically and making sure that people aren't, shoving lots of data up into public LLMs and out onto the internet unknowingly.
And I want to take
I'm sorry, Bill. I just wanted to open this up a little bit. We've been talking and talking. I'm just curious, and Bill, I'll just let you finish up, and then we'll open it up for questions. Any questions that anybody has? What's that?
Yeah, I just wanted to go back what Andrew spoke about with the working groups. That is really, really important. Anybody who knows me knows I'm a believer in employee task forces, as we call them, at Thrive.
And that one started at my health center.
Yeah, Dr. Powell knows we have one going at her health center, which is, folks across the board, right? We have a provider, we have front end staff, MAs, nursing, guy from finance. So deploying it through these task forces is really going to help minimize missing something. A lot of times it's driven just by leadership. And when you do that, you don't have the people working day in and day out addressing what the true needs are. So I think those task forces are critical to success.
Thank you, Bill. So let's, I know that you have different AI agent types that might give us some examples of how this is used. And if everybody can start to put their questions while he's going through that, just a quick review of that slide, put your questions in the chat so that we can hear from you and address your questions and concerns.
Sure. Yeah, if we could bring the slide up that has the agent types. This is helpful. This is not official. This isn't a technical standard by any stretch, but it is a representation that helps people understand kind of in human terms and language what any particular agent might do. And again, in an agentic workflow where you might have multiple agents, of course you incorporate multiple of these capabilities.
Thank you. We have one question in the chat now. If a health center has already begun their implementation of AI using one method, but after this they wish to switch to a different approach of model, what should they do? Is it too late to change models or approaches, i.e. vendor versus partnership?
Not at all. And that's a great question. And in fact, I would say that with technology generally, with IT, I would say generally, and with AI very specifically, the ability to switch gears is inherent. As AI developers, our team routinely move from one model to the next when it comes to the higher reasoning models and for writing code and doing things that are very complex. They switch all the time because they're following what the best of the technology can produce right now today. So if you've already started using something in one way, it really depends on the workflow, but you would want to look at it through the same traditional lens that you always have. You'd say, what information has sort of been produced already? Is it already in the database, so to speak? And, can we port it? Can we move it into another solution? Of course, if there's PHI in there, you have to be able to. And so whatever that arrangement kind of looks like today, it's sort of similar to what you've done in the past, moving from one system to another. It's important to realize that on the surface, the AI is doing something that's new and a bit unique in this reasoning and that sort of thing. But directly underneath that is very traditional block and tackle information technology. So there are databases full of tables, full of patients, and full of all these records, and you can go in and extract that information and move it. And you have to be able to. That's a requirement of the compliance as it sits today. So whatever that solution looks like. Now, if it's a public LLM that's been being used in sort of a very inappropriate way, then that would not be something that you would quite as easily be able to export. You could export some of the logic. You could go to that chatbot and say, hey, I need to kind of lift and move this to another solution, and this is what that solution is going to look like. Can you provide me some prompting or some reference material or a detailed plan or architecture? They're very good at producing things like that. But again, they can only really produce something that's as useful as the most capable human being you have associated with that same thing. So what I mean by that is that you can go to a chatbot or to an LLM and ask it to formulate you a very, very complex technical task. And anyone who doesn't understand everything that's in it might read it and go, gosh, that's amazing. It looks perfect. I can't see anything wrong with it. And then a human technologist that knows how to do that exact thing would read it and say, this is actually 95% accurate, but some of this is actually not accurate, and it needs to be modified in this way or these, ways here in order to work. So the long story short is it really kind of depends on how that's been enabled so far, where that data lives, and what that process would look like to get the data to move on, presuming that historical data is actually germane and relevant to the function of the AI, which is not always the case. So something that's very real time and verifying something today and then also doing it again a week from now, it may not matter as much, what it verified, 6 months ago.
I have another question that's in the chat. With a diverse, largely minority communities health centers serve, how concerned should we be about bias in AI algorithms that may have been trained on data from majority populations?
I would say fairly to very. And we've talked a little bit about this offline. And this goes back to what we said earlier, that AI, the large public models, have been trained on public and cultural data that exists today. And so it's, while this gets a little bit more into sort of philosophy and that sort of thing, I personally believe that people ought to see that as an accurate reflection. So when we see that bias, it does exist. It does exist in the information, the collective data that humanity has produced. And so it's important. It's a mirror for us to look at and say, hey, this is this technology that's now sort of in everyone's face clearly has been trained on information that is not truly reflective of a diverse population. And so again, the difference between AI platform, for example, if that's your kind of chosen solution source, you really can't change what are called the weights or the system instructions, the sort of underlying code that guides what that chatbot, for example, or what an agent developed out of, say, OpenAI or something like that does. Whereas and neither can you really in a vendor embedded AI. They're the ones that are dictating those extra instructions that you as a user don't necessarily see or have any influence. But again, when we go to custom and AI development partnership, well, then your development partner can absolutely give you full control over that, because we can use what are called open source or open weight models, and then we can provide them the types of instructions and descriptions of the context of the work that they're doing and with whom they're doing it and why it's important. And that is what goes into every calculation, if you will, every sort of reasoning step that it takes. These are the instructions that it takes first and foremost. So even if you go and you ask it a question, explain this aspect of this social determinant of health to me, as it gets that submission, it actually reads these system instructions every time first. And so it always knows kind of where it's rooted, what its primary mission is, what its sort of values are, if you will. And these agents, these little sort of software programs, are instructed accordingly. And so you actually have the ability to have that influence and control depending on the type of solution that you are looking to develop, and importantly, who you're working with to develop it.
And I think it's very important to, with this, health centers have to deliver culturally competent care to their patients. And in order to develop that culturally competent care through an AI model, you have to be very specific on your particular community and your particular patient panel. And certainly that's a lot easier to develop those intricacies through a development partnership. Whereas to Andrew's point, something out of the box is going to have some bias to it, more than likely.
Yeah. And importantly, the customization that we're talking about is still using that same bias, even if it's an open source model, it still has the biases because the data that trained it, again, was biased to cultural realities that are real and systemic, and that we're all more and more aware of all the time, and understand that we would very much like to, we have to accept and absorb and see as real so that we can finally know ourselves beyond that as a society. But until we have done that, this will allow us to provide some extra instructions to that model that says, like, hey, this is how you really ought to operate, and things that you need to be sensitive to. And so if it's answering the phone, for example, and there's somebody speaking a different language, well, then it's going to know that, okay, I need to speak, this language. And if there are other nuances and instructions that are around demography or geography or socioeconomics, those can be put into those same open source models.
So, Andrew, if we can go back to the three approaches to the AI adoption, can you just walk through the pros and cons of those three different models? Because I hear for us that are kind of lay people, right? So, and I just have a follow up to what we've been talking about with the cultural competency. Before we do that, will it learn? Will it improve? If as it's exposed, let's say if it's patient facing with the community and it's dealing with different scenarios, does these AI chatbots, will it be able to adapt and improve with cultural competency?
Yes, because you can start to train and tune your own model. So we actually have the ability to start with sort of an open source model, and then as the system is used and as the feedback is provided and as that human in the loop continues to interact with the data, it can continue to improve based on sort of what we call a win condition, right? Like what's the most optimal thing here? And when the user says, yes, this is very optimal, and the user might be a staff member or it might be a patient, just depends on how that metric is collected. But when it's reinforced, then it will start doing better and different approaches. Going back to those three approaches, sort of like high level pros and cons, real quick, going through an AI platform. OpenAI was the first and the very biggest, super powerful. 5.1, which is GPT, is sort of their latest and greatest model, has now only maybe just now been surpassed by Gemini 3, which was released like yesterday or the day before, which is Google's model. Super powerful, lots of reasoning capability, which, by the way, is used relatively seldom in the types of solutions and workflows that we're talking about. It's good at doing very deep research and thinking of lots of different things from a lot of different angles. But when you're saying, hey, can you read this insurance card, see the information that's on it, and then go find, whether or not this patient is eligible for X, Y, or Z procedures or something like that, that's very different. And so the model utilization is very different. But the big platforms like OpenAI have lots and lots of power and capability, but they can also be very expensive because you've got to have somebody that can then build those agents. You've got to have somebody that can use that platform to build agents to perform all of those functions. You also have to engage with them at a way that is compliant, which generally means they're enterprise level solutions, which cost a lot more even per user. And so it can get very expensive. And so they don't really have solutions that are tailored for the nonprofit space specifically. So those are kind of the pros and cons of the platform itself, just like an OpenAI. It's like, gosh, super powerful, but if you don't know how to make it do what it needs to do, and you can't afford to have them keep all your data separated and compliant, then is that really a solution? The vendor embedded AI, the pro there is that it can be very easy to implement because it might just be as simple as just flipping a switch or calling up your EMR vendor or your LMS or your GRC and saying, hey, I'd like that new feature. And they may not charge you very much for it either, because they've developed it once and want to deploy it to as many customers as possible. So it can be very attainable and very easy to deploy very quickly, but it's not going to be very flexible, and it's not going to have the ability to have you make customizations around things like cultural competency, for example, or because you've got a workflow that works slightly different than the way they had originally designed it to work. And so again, the pro is it can be very fast to deploy because it's already been developed. The downside is that it's less flexible and doesn't tend to reach really outside of the application that it was built into very well. So, you're not going to go to your EMR vendor to get something for the accounting workflow like we talked about earlier. And if your accounting platform is not already actively integrating AI into their workflows, they may not be able to satisfy that either. And to the point that Bill brought up earlier, if you want to have something that brings all these things together, they're not going to do that for you. So you lack flexibility, but you get affordability when you do vendor embedded AI. And lastly, with an AI development partnership, this is where you really start to build out what is your own custom AI framework that connects these various applications and databases and all the different sources of information that we want to bring in and analyze, and allows you to work with it, visualize it, chat with it, work how you would like it to do. And it can perform functions. It can act on things based on you saying, hey, if this or that or this other thing happens or comes through or bubbles up in this particular workflow, then we want it to be dealt with like this. And just like a human, you train it. You go in and you say, hey, here's this other edge case. This came up. You call your developer and say, hey, this thing came up and we need to be able to account for this. And unlike calling, say, your EMR vendor and saying, hey, Dr. So-and-so really doesn't like it when this thing happens. I mean, they're not going to really, do anything with that. But with your development partner, they're going to go, yeah, tell us exactly what you would like to have happen when X, Y, or Z happens. And that's what we're going to do.
So let me, just want to just close this out because you talked about financial. And real quick, before we close out, how cost effective is this for me as a federally qualified health insurer to bring in something that overlays on our systems? And if we could just touch that briefly before we close out, because this has been a wonderful start to this series. But if we can end on that last question.
Sure. Absolutely. It can be very cost effective and much more so than, like I said, traditional software development used to be. In fact, that was not even an option. Most health centers today couldn't redevelop a new application from scratch if they wanted to, because it's just a very, very expensive endeavor. But now the AI itself is used to produce much of the code that's used even programmatically throughout the process. And so the development cycles have just gotten so much shorter to where this can be done for very little upfront development cost at all. And depending on who you partner with, you may have little to even no development costs associated with that. And it's not going to be used heavily or billed thoroughly until it is used heavily, and all the value is being pulled back out of that. And people are saying, like, yeah, this workflow is doing exactly what we expected it to do. I've even started to think of things like value-based, reimbursement, like starting to look at some of the mechanics that exist within the community health space and saying, is there a way for service providers and partners to start to put some of their pricing models and put their money where kind of the collective mouth is, even in this industry and in this space. And so can we help share some of that risk, frankly, rather than putting that all on the health center and saying, okay, this may or may not work, and you're going to be tens of thousands of dollars into it by the time we find out? I don't think so. I think that we're going to have to help bridge that gap to get there.
And I think that starting with those smaller tasks is very important, right? Because you can identify return on investment on some that shows an immediate impact on your organization. So this is not an all at once. This is a step process for health centers. And again, if you set goals, you start with some of these smaller tasks, and evaluate your expected return on investment with your actual return on investment. That's lessons learned for when you get to bigger deployments.
Thank you so much. I think, with that, what a great way to end that. This has been a wonderful conversation and a great way to start this journey. And I am so looking forward to hearing more with remember, we have additional sessions, so please register for those sessions. And I really thank you for all that you have done and said so far. And I think this will be helpful for us. So thank you so much.
Thank you, Dr. Powell. On screen, I think we have right now actually a breakdown of what the next session is going to be. And this is very much a work in progress as we go. And so the questions that we're getting from the community are basically the same ones that Bill and I have been encountering as we've been communicating with health centers across conferences and as we do the work that we do with them. And so it's going to continue to evolve. And right now we've got at least 4 more sessions where we're going to do some kind of more deep dives into this.
Yeah, I mean, we're bringing Dr. Roberts into the clinical discussion. We'll have other team members on the operational and finance portions of this. And so I'm excited about the future sessions here.
Yeah, likewise. Great. And we'll do one that's a bit more on the technical side as well, to get into compliance and security guardrails and things like that. So there will be something for pretty much everyone. And I think we have one more slide too with some contact information for anyone that is sort of already chomping at the bit. We've already started having these conversations with a number of health centers. There are people who are very much ready to start this journey. So we've got some information there. If you're ready to start getting your arms around, I think the strategy side and standing up, things like task force and all that, I think Bill and his team are going to be perfect to reach out to. If you have particular workflows or something already pretty specific in mind, and you've got questions around what that technology might look like or how it might work, and you want to reach out to me, I'm certainly here as well.
Well, thank you so much. Everybody have a good one.
Thanks, everyone.
Bye.